You're watching Grassroots Community TV, the nation's original community-operated television station, protecting and nurturing open channels of communication for the citizens of the Roaring Fork Valley since 1972.
My name is Frida Wallison. I'm the chair of the Pitkin County Republicans, and I am very pleased to welcome all of you here today. This is actually a repeat performance on the part of Steve Hyde, who has been kind enough to come over here from Colorado Springs, where he is based. He's in the healthcare field, has been for 35 years, in a variety of capacities, and really knows an awful lot about the healthcare field, where it's been, where it is, and where it may be going in the future. There's been obviously a lot of discussion about Medicare in particular, I would say, in the current time on that subject. Steve is, among a lot of other things, the author of a book that he wrote before or during just about the same time
as it was published just before
the health care law was passed.
Right. They didn't read it.
But and he's observed that if they had taken his advice, whoever the they is, that maybe we'd have a better resolution. But the name of the book is Cured: The Insider's Handbook for Health Care Reform. It's a very thoughtful piece of work, and I gather you're selling these, if anybody is interested, at $20.
Yep.
And you have some extra copies
with
you. You happen to have. He'll also tell you about how you can download parts of it on Amazon for less money.
For nothing.
So I'm going to hand the mic over to Steve, or he has his own mic, and then we'll use this to, with this kind of an intimate group, we can have a really free-ranging discussion, and we'd like to do that. We are on Grassroots TV. And so the more information that comes out of this event, I think the better. With that, Steve.
Thank you, Frida. Thank you. Thank you for having me. Where do I put this? Buddy. No, it's all right. It's great to be here. Thank you all for having me. I feel like I need to give you a couple of disclaimers. I don't know why Frida invites me to do this, because I'm not a Republican. I've never been a Republican. In fact, the only time I ever had a party affiliation was as a Democrat, because in Louisiana back in the day, if you didn't vote in the Democratic primary, your vote didn't count. But I'm an independent now. I'm not a political type. I'm a healthcare geek. I'm a healthcare policy, strategy, and operations geek. I mean, for God's sake, I used to be a managed care actuary. Actuary, of course, is somebody who doesn't have enough personality to be an accountant. I was known as the extroverted actuary, because instead of staring at my shoes when I talk to you, I stared at your shoes when I talk to you. Let's talk about Medicare. In the question and answer, I can talk about a lot of different aspects of healthcare reform, but Medicare is the big issue right now in the political campaign. I don't think there's any healthcare issues, certainly, and few other issues being put front and center in the campaign that have shed more heat and less light than the Medicare debate. So I'd like to talk about that. The two opposing sides I'm going to call the president's position and the Romney-Ryan, which I will shorthand as the Ryan approach, since he's the one who's been most active in digging into it, and he's the one most tied to what is now the Romney-Ryan proposal. The president has characterized the Ryan approach as threatening to end Medicare as we know it. Some interesting thoughts on that, to me at least. Senator Joe Lieberman used to be a Democrat, still votes in the Democratic caucus. And this is a quote. He said, "We can't save Medicare as we know it. We can only save Medicare if we change it." And of course he's right. Everybody knows, both sides, that Medicare is unsustainable on its current path. There are two major trust funds, the Part A, funded by the government, Part B, funded by withholdings. Both are going broke. The Medicare A trust fund is projected to run out of money in 5 years. The Medicare B trust fund in 14 years. It can't be sustained at the current rate. What's really interesting, though, about the Ryan proposal is it's not really his. The original idea, or one of the institutional version, actually came out of a presidential commission under President Clinton in the 1990s. It was chaired by Democratic Senator John Breaux, and they came out with this idea of either voucherizing or premium support for Medicare and giving a choice between traditional government Medicare or private insurance. And indeed, the Ryan proposal is either similar to or co-authored with, that doesn't fit, but anyway, Ron Wyden, senator, Democratic senator from Oregon, Janet Rivlin, a brilliant budget analyst, used to run OMB, was the first head of the Congressional Budget Office. She's on one of President Obama's fiscal responsibility councils, extremely bright woman. She has signed on to a joint version of what's called the Ryan-Rivlin plan, which is very similar to the plan currently on the Republican platform, or the Romney-Ryan proposal. So the Ryan proposal has some pretty deep roots of a bipartisan nature. And it's kind of interesting that the president himself has kind of gone off message from what has been a fairly consistent approach from Democrats who have really dug into it, really understand it, really know what they're talking about. So what is it that Ryan proposes? What he is proposing, I'm sure you've heard it, is that Medicare beneficiaries should have a choice between going with the traditional Medicare plan run by the government, Parts A, B, and now D, the drug plan, or buying the same level of benefits, perhaps plus more, from private insurance companies, with having a choice once a year to sign up for those. Same or better benefits on the private side, with the same government payment, regardless of whether you go with the government plan or the private plan. So the president's charging, he clearly doesn't like the plan. And he claims three things. He said Ryan wants to voucherize Medicare. Ryan's term is premium support. There's not a page width worth of difference between the two. Wants to voucherize Medicare, wants to cut Medicare, and wants to increase the beneficiary payments by $6,400 a year. That's the claim. Let's look at those. The voucherizing piece is the one that perplexes me the most. Because in fact, Medicare, we were just talking about that, has been voucherized since 1983. They have a very robust system now called Medicare Advantage, where everybody on Medicare currently has a choice. They can go with a government program or they can buy private insurance. As far as I know, every state, every county, every market in the United States offers that choice. Medicare Advantage has grown by 30% over the last 5 years. Now more than a quarter of all Medicare beneficiaries are under Medicare Advantage. It's 27%. 40% of baby boomers, like me, who are now aging into the program, are signing up for Medicare Advantage. So the charge that Medicare would be voucherized under Ryan, it doesn't hold water simply because it's already voucherized, and that aspect of Ryan's proposal is not substantially different from what we have now. The second charge that he would cut Medicare also doesn't hold up, because both the president, as embodied in the Affordable Care Act, sometimes known as Obamacare, proposes to limit the growth in Medicare spending to growth in national GDP plus 0.5%. So he wants to limit the growth to just over the growth in GDP. Paul Ryan proposes to limit the growth to GDP plus 0.5%. They're exactly the same. There are no cuts involved. It is limiting growth. But Medicare right now is about 3.25% of GDP. In, I think, 5 years, under either Obama or Ryan, it would be about 3.5%. So there's not a dime's worth of difference between them there, and it's not cutting at all, except in Washington speak. Only in Washington, in the political circles, does reducing the growth in spending count as a cut. And both sides use that argument all the time. It's kind of cute. Oh, the $6,400 that the Ryan plan will cost $6,400 more per year for Medicare eligibles. I don't know where they get that. Because under the Ryan plan, everybody on Medicare will have at least one option that doesn't cost them any more than the government is willing to pay for the Medicare benefits. And will have at least one option that's less expensive than that, same level of benefits, one option that's less expensive than that, where the difference between what the government would pay for the next higher up and the lowest cost gets paid to the beneficiary. So if the government's putting in, I'm making up a number, $1,000 a month for your Medicare, you will be guaranteed to have at least one health plan at $1,000 a month. So the government's payment will cover it. Now, if you want extra stuff, you can pay for that. But you will also have a lower price plan that, let's say it's $950 a month. The government would write you a check, if you take that one, for $600 a year. So you actually get the benefit of that. I'll come back around to that before I finish and put some real numbers on that. So none of the three charges really have any meaning, which it's what has been characterized as meta-scare by the Democrats. But something is clearly bothering them. I mean, if it's not those three things, because they're very smart people, they know all of this, it's not going to be a surprise to them. What is it that's bothering them? And maybe I project, but you got to try to figure out where that's coming from. One thing that's clear, that, to me at least, the Democrats have been on the defensive on Medicare, which they've never been before. The Democrats have owned Medicare since its inception under Lyndon Johnson. It's been their issues. Suddenly, you've got an opponent, Paul Ryan, who has articulated pretty well, not as well as he should have, in my view, but pretty well, an alternate view, an alternate approach that preserves Medicare, preserves the benefits, preserves that promise, and does it in what he claims to be a fiscally responsible, long-term, sustainable fashion. And I think that has put, when the President of the United States says the other guy, when you ask about what is the issue on Medicare, Paul Ryan wants to voucherize it. That, to me, is a defensive statement. There's nothing positive in that. So part of that, I write off to politics. Okay, whatever the other side comes up with, you got to be against it. And if we can't come up with factual stuff, at least on voucherizing, cutting, and costing more, let's at least engage in fear. And both sides do that. But I think there's something else there in terms of the Democratic response to this. I think they are legitimately fearful of what it means. Because it's not just the Democrats who have always owned Medicare. Because it has become such a huge piece of the total government spend, and it has grown certainly as a percentage of what the government spends and as GDP, that it's a huge power base for the Democratic Party. It's a huge base of patronage. It's a huge base of vote getting. And I think the main thing that Ryan's proposal does is it's created a fear that the Democrats could lose that, but the government could lose control of it. Because essentially what Ryan is talking about is taking the decision authority away from the government in terms of what your benefits are, what you can pay for it, and giving it to the individuals. Because when you think about giving a voucher or premium support to individuals, you're saying, here, you control the money. You make the decisions. We'll screen insurance companies. We'll make sure they're all high quality, that they all provide these benefits. If they do bad things, if they have less than a 3-star quality rating, we'll kick them out. We'll have all of these things. We'll do the risk adjustments so nobody can game the system by getting healthier patients. And they actually do a reasonably good job of those things. But we, the government, are just going to become a funding agent. We're going to give you the money and let you make your own choices about what health insurance you want to sign up for. So I think that may be the fear, but again, I may be projecting. And I don't do politics very well. So if there's no difference in what the two sides are saying, is there a real difference? And actually there is. There's a very big difference between the two sides, because even though both want to limit spending growth, GDP plus 0.5%, they want to do it by entirely different measures. The Obama Affordable Care Act approach is top-down, command and control. I call it the doctor science approach, where the president is saying, I know more than you do. I and my agencies and bureaucracies and incredibly smart people can decide how best to spend those hundreds of billions of dollars, what to spend it on, because we know that 40% of everything that doctors and hospitals do is wasted. It adds no patient value at all. And we are going to determine what those things are, and we're not going to pay for it. So that's their approach. It's top-down command and control. And the Affordable Care Act embodies that. There are 165 different provisions in the Affordable Care Act that get at that piece, saying, in the past, all of our top-down attempts to control spending in Medicare have failed. So therefore, it's very clear we just got to double down and do it some more. Of the 165 provisions, the uber provision, the one that gets defaulted to, if all the other ones fail, and some of them will succeed. I mean, you throw that much stuff against the wall, some of it's going to stick. A lot of it won't, in my view. And history is not encouraging that it will. But the uber provision is something called IPAB, which apparently has not been copyrighted by Apple. It stands for the Independent Payment Advisory Board for Medicare. And it will consist of 15 presumably very bright, very politically connected people who will be charged with the task of, when spending does go above growth in GDP plus 0.5%, they'll say, okay, we get to decide where to just cut. We can't cut benefits per se, but we can stop paying for stuff that doctors do if we decide it doesn't work. The IPAB is based on, the idea came up essentially from former Senate Majority Leader Tom Daschle, who is a big admirer of a British agency. It's called the National Institute for Health and Care something, I forget, excellence. And it has the Orwellian acronym of all times, NICE, N-I-C-E. It's the NICE agency. And their job is to keep a lid on spending in the British National Health Service. And the way they do it is very simple. They said, we will only pay for things that are worth it. How do we determine whether something's worth it or not? Well, we're going to look at everything doctors and hospitals do. All the procedures, the drug therapies, the treatment plans, and we're going to determine, especially for the most expensive ones, how many, on average, how many quality adjusted life years get added to patients' lives from this therapy. So you got a transplant procedure. You say, okay, let's say it adds X quality adjusted life years to the average patient. And then they look and they say, how much does it cost per quality adjusted life year to do that? And then it's a very simple algorithm from there. If it costs more than the equivalent of $45,000 per quality adjusted life year, they won't pay for it. They won't do it. So if you are over 70 and you get a bad blood transfusion and you get hepatitis C and you end up needing a liver transplant, they do that little formula and it will extend your life with a transplanted liver, but you're already 75 years old. There ain't going to be enough quality adjusted life years to get that cost down to $45,000. So you won't get it. And in fact, it's much more difficult for the elderly to get organ transplants in England than it is here. Here it's standard. Cancer therapies, big one. You know, there's some hideously expensive cancer meds out there now. Effective, especially when they do the genetic targeting to know where it will be effective. The NICE agency took one look at most of those and said, these don't work, we won't pay for them, we won't cover them. And they're not covered there. These are standard therapies in the United States. So as a result of this and other things with the National Health Service, cancer survival rates in England are significantly below ours. I forget the exact numbers, but there happens to be a book with all this stuff in it. So that's the approach of the Obama administration. It's take money away from the providers. And it's not even a simple saying, okay, if the costs go up too much, we're going to take it away from the providers. And before we get to this IPAB board, we've got all these programs to push it down, these 165 things. It's not as simple saying, well, we're 5% overspending, so we're going to cut provider reimbursements by 5%. Oh no, you got 165 things with 165 sets of regulation, 165 bureaucracies. It's a nightmare. You got stuff like the value-based purchasing program in Medicare, the pioneer ACOs, the shared savings, accountable care organizations, the bundle payment initiative, something called the Center for Medicare and Medicaid Innovation that has a plethora of demonstration projects out there to figure out how to save money. By the way, I said Daschle is responsible for IPAB. There are actually at least 3 predecessor organizations in the government. There was a National Center for Health Care Technology, there was the Office of Technology Assessment, and there was the Council on Health Care Technology. All were set up over the past 25 years to essentially do the same thing IPAB does. They all failed. They're all gone. They've been defunded and disappeared. Rarity in that culture. IPAB has one thing they don't have, and it has teeth. And you could argue it's super congressional teeth, because the law that the Affordable Care Act actually gives IPAB the ability to say, we are not going to pay for these things. And the only thing that can stop that is not just a congressional override, but a congressional override in which the Congress also figures out someplace else to save the amount of money that they were going to save. Congress has tied its own hands. It's sort of like the Base Closure Commission, saying we don't trust ourselves because every time we tried this before, the special interests come in, they roll over us, and they change it. So that's the president's approach. What does Ryan want to do? President's top-down. The Ryan is a bottom-up competitive bidding process. What he wants is for all of these health insurance companies that are selling into Medicare, they've met all the screens, they meet the quality requirements, they got the providers, all this stuff. Once a year, he wants them to bid. Say, for this fixed basket of Medicare goods and services, how much will you charge? Now, they actually do that now. They do it for different reasons in the Medicare Advantage program. But what Ryan wants is the government also to bid and say, for parts A, B, and D, this is how much we will charge, or we will, it will cost under our current program. Then Ryan wants to line them up, top to bottom, take the second lowest, not the lowest, second lowest bid and say, that's how much the government will pay. So you, Medicare folks, there are a couple in here. You Medicare folks, you can sign up for any of these you want. But you will always have at least one plan, that's the second lowest bid, that the government will pay at all for the at least the Medicare portion of benefits. And you'll have at least one plan, the lowest bid, that will cost less than the government contribution, and the government will pay you the difference. Anything above that, you're welcome to sign up for it, but you pay the difference. And therein, I think, lies the fear factor on the part of the Democrats, because there's a lot of solid evidence that the government's program will not be certainly the next to lowest or the lowest bid. And before you jump in with saying, well, oh yeah, but the government is handicapped because they get sicker patients. Don't worry about that part, because Medicare factors that out now. They have something called risk adjustments. It's an HCC hierarchical cost thing, where they do risk adjustments based on the actual patients that come into a health plan. So with Medicare Advantage now, if you've got one Advantage plan that's getting sicker patients, they actually get an adjustment in higher revenue from the government, which is offset by reduced payments to the Medicare Advantage plans that got the healthier patients. In fact, it's to the point now where really good health plans are really good at managing patient care and coordinating the care, are actively seeking the sickest patients because they know they're the most expensive. They can provide really good care, keep them in the home, maintain their health status at a higher level. They don't go through the ER and the inpatient every 25 days, and they cost a lot less than they can make a lot of money on them. So there's actually positive selection for sick people in the Medicare program. So you can't argue that. Well, you might argue, okay, the lowest cost plan, those are the guys that scrimp on care. There are all these, we were talking about the HMO horror stories of the 90s. There were some, I argue a few, but enough to damn the whole bunch of them, that turn the decision of what you cover on Medicare over to the bean counters, the actuaries and the accountants, rather than the doctors. Now, I ran health plans. I started 9 of them. I ran a public company that did them. We never did that. We always said the doctors decide what the patient needs and what they get. We saved tons of money that way. We made a lot of money. Everything worked well. 99% patient satisfaction. So there's nothing inherent in the HMO model that's negative, but there were people that thought, wow, we can just keep screwing it down, and they screwed themselves out of a market dominance. So the Ryan approach is competitive bidding. Oh, I'm sorry. I was saying the issue of scrimping. They can't do that anymore. They can't get away with it. Medicare now has, for Medicare Advantage program, this 5-star system. And if you don't get at least 3 stars, they pay you a lot less. And ultimately, you'll have to get 4 or 5 stars. 3 stars is average quality. Quality includes a huge dose of patient satisfaction. So not only will Medicare pay you less if you're lower quality, if you do it consistently, they'll kick you out of the program. But there's an even more powerful control over quality and patient satisfaction. And that's the annual open enrollment period. Anybody who joins a plan, they feel like they get jacked around, they're not treated well, they don't get good care. A year later, they bail out and they go somewhere else. And plans have died when that happens. So there are mechanisms now that weren't necessarily in place under the old HMO era. One of the reasons HMOs failed is because when they became sole choice, you had no choice to go anywhere else. People didn't like them. As long as you had a choice to go somewhere else, they actually worked pretty well. But they had rules and they had limited networks and all of that. And if you're happy with it, great. If you're not, go with somewhere else. So those are the primary differences. So top-down control and more bottom-up competitive, using more market principles. There's another aspect of the lowest cost health plan and quality that's really, really important, because in the last 10 years or so, they have made major strides in actually objectively measuring the quality of care, which is something we could never do back in the era of managed care, where you can objectively manage that doctors are doing the right thing according to generally accepted medical practices, and that the patient outcomes are better or worse for things like infections, recovery times, mortality rates, complication rates, all this stuff. Increasingly, we're measuring it because we can do it now with electronic medical records. Paper records, you could never do that. So we're beginning to apply scorecards to doctors and hospitals. Are you doing the right things, and are you producing the right results? What we have learned and are in the process of learning is extremely interesting. The higher the quality you produce, the lower the patient costs you get out of it. I'll give you my best example, my favorite example. Duke University Hospital System 10 years ago decided to implement this really dynamic disease management program for something called congestive heart failure, CHF. It's not like a heart attack. It's a chronic disease. It's a very expensive chronic disease. It's where people are in their homes. Maybe they go out for the 4th of July. They eat a hot dog, too much salt, fluid retention. They go into congestive heart failure. They have trouble breathing. The heart has trouble pumping. Into the emergency room, into the inpatient bed, spend tens of thousands of dollars stabilizing the patient, discharge them, send them home. They're religious as hell for, maybe a week or two, and taking their meds and controlling their diet and all that, and then they fall off and they're back in the hospital, the readmissions. So Duke said, we don't want that to happen. We want to have active outreach to these patients. We'll have nurses that call them. We'll have them weigh themselves every day, sometimes on electronic scales. So, because sudden weight gain is a big sign for congestive heart failure, they tell me. I'm not a doctor. I had no formal education. I was a business major for 6 years. They make sure the patients are getting in to see their cardiologists and the primary care physicians. They're making sure they're taking their meds, which a huge number of people don't. They're sending nutritionists into the home just to go through their cupboards and refrigerators and make some suggestions about changing their diet. They throw away their salt shakers. It has a dramatic impact on the quality of life of these people. The incidence of ER and hospital utilization plummeted. The people are living in the home. They're much healthier. The cost of treating congestive heart failure patients dropped by 40%. So here's a great example. You do the right things, you get the right outcome, and by keeping people out of the hospital and the ER and the imaging centers and the specialty care and all that, you've dramatically cut the cost of health care. That's one little example. There are thousands and thousands of them that we're learning. When you improve the quality of care, the objective quality of care, you dramatically lower costs. So now, segue to health plans under Medicare. You put together a health plan that says, you know, we want to change the nickname of the person who graduates at the bottom of their medical school class. You know what the nickname is? Doctor. They graduated, you know. You want to find out who the really good surgeons are? You know, the ones with brains in their fingers versus the butchers, and they're out there. Let's take a medical device technician or salesperson, or if you're really lucky, an OR nurse out, put 3 or 4 glasses of wine in them and have them start talking about the doctors they work with. Because the device salesmen are regularly scrubbing into surgery and assisting surgeries. They're putting in all these different devices they're selling. And that's when you find out, who you would never go to ever as a doctor. The doctors all know, but code of silence, they don't do that because most of them don't know where they are on that scale. So you got a health plan that says, we're going to get rid of those guys. We're not going to call them doctor anymore. We'll have a different nickname for them. Maybe, I don't know, professor. I'm sure I offended somebody there. We're only going to do high-quality doctors that measure things because we've learned something really cool, that once you start measuring doctors against objective criteria for doing the right thing and producing the right results, all you have to do is show them the results. These are all people who are used to getting A's. You tell them what the grading scale is, and they'll all fight to get A's, except the ones that can't or won't do it, and you want to get them out of the profession. Then everybody gets better at it. And you don't have to do much else. And there are tons of demonstrations around this all over the place. So you got a health plan that focuses on that, that eliminates hospital-caused infections, which you can do with a 5-point checklist. Half the hospitals in the United States don't do it. So you go in, you get sicker because of something you didn't go in with. You get rid of those things. You put in place all of these quality assurance methods. You do the right thing the first time. Costs of care plummet. It's reflected in lower premiums for your health plan, for your Medicare health plan. So you're one of the guys down there in the neighborhood of the next to lowest or the lowest cost. So when people figure out, because they control the money, they've got the voucher, that, wow, I get to choose. And now I can get information on quality and price, and I got the money, I'm in control of the money. People tend to make the right decisions. Markets work because the majority of people, the majority of the time, make rational enough decisions to make market capitalism function better than any other known system of economic organization for creating and distributing wealth. It just is. Nobody knows why it works, by the way. It's just kind of an emergent property of humanity. Markets are incredibly messy, incredibly inefficient, as we've seen over the last several years. But at bottom, you can paraphrase, Winston Churchill's quote about democracy. You paraphrase that, you say markets are the worst conceivable form of economic organization except for everything else that's been tried. And we know from the fact that we all buy everything else in a system where we control the money, we get to measure, do our own determinations of quality, fitness for use, appropriateness, and price. Food, clothes, housing, transportation, recreation. We get to make that calculation. We get to ask the questions. We get to go on the internet and find out which car meets my needs. If I put a high value on luxury, I want to know, I'm in the Lexus Mercedes area. If I want the highest mileage, the greatest bang for my dollar, I'll go with the Ford Focus or whatever. But I get to determine because I control the money. So what I like about the Ryan plan is that. But the question is, will it work? What would be the impact if we do that? And it turns out there is a lot of information to feed that. David Cutler, who's a Harvard healthcare economist, it's almost an oxymoron, but not quite. He's a Democrat. He's been an advisor to President Obama on health reform. Just came out with a study he co-authored with some other folks. And again, remember I mentioned that Medicare Advantage plans do the bidding process now. They just don't use it the way Ryan wants to. They went and actually analyzed those bids and said, okay, what is the next to the lowest bid? All across the country, because the plans are different. And they found that the next to lowest bid on average is 9% cheaper than Medicare fee-for-service, which means if we implemented Ryan's approach today, we'd be saving $50 billion a year on Medicare. Now, the Democrats, I suspect, would argue, but wait a minute, you've just made the government program more expensive. The people that want to stay with the government program are going to have to pay more money, which is true. But then you ask the question, why would they want to do that? If the lowest cost plans are the highest quality plans, and they get to not only spend less money, but maybe get a rebate back from the government, why wouldn't they want to do that? And I suspect that's at the root of why the Democrats are so unhappy with this proposal, because it does remove the power. By the way, the lowest bid that came out of the Cutler report was 5 percentage points below that, which means if everybody on Medicare went with the lowest bid, they'd get a check averaging about $500 a year from the government with the lowest cost health plan. But even if they just went with the next to lowest bid, would say $50 billion a year now, but you look at the baby boomer growth and inflation, that's knocking up against $1 trillion in 10 years. You know, 10 billion here, 10 billion there, pretty soon. So one of my few disappointments with the Ryan approach, he doesn't want to apply this except for people who are now 55 or under. And I'm thinking, gee, you've already got the voucherizing. People already have the choice. Why don't you do it now? The government will save $50 billion a year. They're not ready to do that. It's disappointing that Romney Ryan hasn't figured out how to say what I just said in 45 minutes in a soundbite. Because voucherizing Medicare, cutting Medicare, and increasing costs by $6,400, that's soundbiteable. Not true, but it does raise the fear factor, and they're not coming up with that. My other disappointment is Romney Ryan hasn't come up with a parallel approach to private insurance, because private insurance is a disaster. Employer-based insurance is a total failure. It's terminal. It isn't going to survive because costs are going up uncontrollably. They have no control of quality. They need something else. What Ryan is proposing for Medicare actually could be a model for a single individual marketplace where everybody can go in and make their own choice of insurance. And the only difference is who's writing the voucher. Medicare will write it for seniors and the disabled, Medicaid for the poor. Employers will write the vouchers for employed folks. But everybody else is in the same market. Guaranteed access to insurance. Nobody gets denied, as long as you don't also let them game the system to wait until they get sick to join, because that'll kill any system in a heartbeat. You do it without mandates. Obama originally was against mandates when he ran in the primaries against Hillary. So net, I like the Ryan approach. I think it's a good model going forward. In terms of President Obama, actually, I think he deserves neither the accolades or the criticism for Obamacare. That's not true, because he actually didn't write it. He had very little role in it. He just said, Congress, you figure it out, and as long as the Democrats control, I'll get behind it, I'll push it, you can put my name on it, which the people have, and I'll sign it. Other than that, he didn't even lead from behind. He didn't lead. He let the Congress do it. And that's why everything that got thrown against the wall, there were no professional actuaries there. Everything that got thrown against the wall got approved. And that's why the Affordable Care Act is such an incredible mess. And why, it's arguably salvageable, but you'd have to dump so much of it that I really do think that just getting rid of it and replacing it with what Paul Ryan has proposed is a seed for it, and expanding that into the individual marketplace and the Medicaid marketplace is a far better approach. Thank you.
Stand up and suggest that we open this discussion to those who are here and hear some of your concerns, thoughts, observations. And
if you could speak into the mic for the...
Yeah, one thing that does concern me is, putting a group together to make certain decisions, the iPad.
All right.
Some of those people are going to make a fortune. They're going to get paid off, lobby fees. How do we police that? They're going to make a fortune at our expense.
Yeah, the question, well, you heard the question. Who polices the police? It's a constant problem in DC. I'm sure they'll vet them, they'll require them to disclose all sorts of stuff. And maybe they'll even succeed in getting people who are so completely divorced from what's going on in healthcare. Not only will they have no conceivable conflicts at all, they won't know what the hell's going on or how to make good decisions. It's kind of it's a great question. I wish I had an answer.
anybody else?
You touched on the Obamacare, how it was created, and we all know the Nancy Pelosi, you have to pass it to know what's in it.
Yeah, right.
Do you know where it came from? It just sort of appeared from heaven or something. Do you know who sponsored it? And
there were more. I used to know who sponsored it and all that, but that, with all the committees that went through on both sides, and the lobbyists, they had to get the drug companies to buy in, the AMA to buy in, the hospital association to buy in. They were cutting all these deals in there, some of which now the people that on the special interest saying, holy crap, I agreed to that. Because now the regulations are coming out. And the regulations are written by different people than wrote the legislation. Democrats were brilliant in the parliamentary approach there. Because remember with Scott Brown, when he was elected senator, he was the spoiler. He was the one killing off the Senate supermajority of the Democrats necessary to get through health reform. Reid and Pelosi got together, checked all the rule books for the Senate and the House, and they said, oh, wait a minute, there's this process called reconciliation. We don't have to get a supermajority as long as it's a budget-related issue. We only have to get 51 votes. They rammed it through on 51 votes. That's how they got it. So there was just a lot of, there were a couple of good things thrown in to the bill. Nobody knows how they got there. They were thrown in at the last minute. Insurance companies now can put as much as between 30 and 50% of premium. They can pay it in rebates back to people who live healthier lifestyles. If they can control their personal health risk factors. There's 6 big ones that predict almost all of the preventable diseases, which count for 75% of all medical spending. There's obesity, smoking, alcohol, drugs, cholesterol, high blood sugar, and high blood pressure. Those 6 things. Individually controllable by most people. So it's actually in the law now that insurance companies can say, you control all of those, I'll give you a rebate of 30% of your premium. You control half of them, I can give you some. That's a good thing. Because giving away free prevention benefits won't do anything. I mean, we did that with HMOs back in the 70s. And it got us nowhere. It got us a diabetes epidemic. Giving people free care doesn't prevent anything. Paying people to live healthier lives works. We know that. So I've answered a lot more than you asked and probably a lot less. But it's just, there were so many hands in that. I don't know if they'll ever find all the fingerprints that went into that thing. But it's an unbelievable mess. You ever heard the joke of the bad kid that wanted a pony for Christmas, but he was a bad kid, so Santa Claus came and left him a note and says, go open the garage door, and he opens the garage door, and there's nothing but horse manure in there because he was a bad kid. And the kid is gleeful. He grabs a shovel and starts shoveling, and his father said, why are you doing that? And he said, it's got to be a pony in here somewhere. There's a pony in the Affordable Care Act, but God, there's so much of this matrix surrounding it that would have to be hosed off that I think is hopeless.
Thank you. So a lot of folks are concerned about the cost to small businesses from the Affordable Care Act.
Oh,
Could you speak to whether the rhetoric we're hearing is accurate, or how does the Affordable Care Act impact small businesses, really?
I'm actually more concerned about the rhetoric you may not be hearing. I had a conversation last week. I got to be careful here because I promised to keep him anonymous. He owns franchise restaurants, low-end fast food restaurants in a state not to be named. And he has about 800 employees. And I said, oh, so under the Affordable Care Act, you have to provide comprehensive health insurance for these people at a cost of less than something like 9% of their average family income, or their actual family income. Most of these people are down around minimum wage. I said, how are you going to survive that? He said, I can't. He says, it's millions and millions of dollars of additional expense. And I said, well, you could pay the penalty. And he said, how much would that cost? I said, well, let's see, 800 employees times $2,000 a year. That's, what is that, $1.6 million? $1.6 million a year, you know. And, you know, he said, that so much exceeds my profit margin. You know, that puts me out of business. He said, what else can I do? I said, well, you can reduce their hours below 30 per week. Then they don't count. He said, that's what I'm going to have to do. So he's actually going to reduce effective employment, full employment, and he's giving serious thought to doing that. Now, Walmart actually likes this because they think it's a competitive advantage. They think we can actually withstand that, and they've actually been proponents of it, but not much else have. So that's one aspect of it that I think writ large across the economy is going to have some pretty serious impact. I don't know what else you're hearing, but the regulations alone that companies are going to have to comply with are just, I mean, it's nightmare stuff on top of, you know, previous nightmares. It's tough. It really makes it tough.
When is all this going to go into effect? It seems like they're talking, planning continuously,
I'll repeat
and
the
nothing
question.
is happening.
Yeah, the question is, when will all this go into effect? A lot of it already has. A lot of minimum benefit requirements, the keeping kids on family policies till they're 26, all the free prevention. A lot of this stuff has come in. The big bang is 2014, January 1st, 2014, when the individual health insurance exchanges pop in, and the dramatic expansion of Medicaid, which will now include everybody in the country who makes at or below 133% of the federal poverty rate.
What about Medicare? What's happening there?
Medicare, a lot of that stuff's already happening and has happened. You hear about the $716 billion reduction that's been pulled out of Medicare. It's a real number. I actually double-checked it this morning. Even the Washington Post, fact-checking blog, said, yep, it's a real number that they took out of Medicare without making it look like they took it out of Medicare, because some of the magic in government accounting. They took it out and then they made it look like they put it back in, which is what took the Part B trust fund out to another 8 years past when it would have gone broke. But that aside, 2/3 of it comes out of providers. We're just cutting payments, cutting payments, cutting payments. We're not cutting benefits. So if you can get to a doctor that's willing to take you, you're fine. But by the way, if any of you are not yet 65 but getting there and you don't have a primary care physician, drop everything and get one now. Because once you get on Medicare, they do not want to take you. A lot of them won't take you in any event. But once you go on Medicare, the reimbursement rates drop to where you become red ink all over the place. Primary care physicians with too many Medicare patients have gone broke. They're pulling out of the program like crazy. So hospitals, a third of the $716 billion comes out of hospitals, roughly a third. Roughly a third comes out of other providers through all kinds of stuff. And a third of it comes out of these Medicare Advantage plans that I mentioned earlier, where the government pays for those as well. I would argue that that should come out, actually. It's about $200 billion over 10 years. Because back in 2003, the Bush administration actually got through something called the Medicare Modernization Act that suddenly paid 12 to 14% more for the private insurance plans, for the same level of benefits, than they were paying on the fee-for-service side. They wanted to benefit and promote insurance. Before that, before the Medicare Act, Modernization Act, the government paid the private insurance companies 95% of what the regular government program costs. So every time somebody signed up for private insurance, the government saved 5%. My health plans used to do that. We made really good money on that because we could manage the care better than almost anybody. So about a third of that, 30%, 30.6%, I think, in my view is legitimate. It should come out that private insurance should be on a par with Medicare. It should certainly not be favored. But the rest of it is screwing down reimbursements for providers. And we know from economics, if you want more of something, you pay more for it. If you want less of it, you pay less of it. Got a huge and growing shortage of primary care physicians, simply and purely because Medicare sets their rates at the bottom of the barrel. If you got kids, grandkids, want to go to medical school, God bless them. If you can get them through without accumulating any debt, then, and they have a strong social conscience, family practice is a great place to go. You know, they make $150,000 a year, and people will love them. But if they're going to have debt and they want to live a little bit higher lifestyle, do not go into primary care. Or if you do, come talk to me and I'll tell them how to make $500,000 a year. But that's a different deal.
Toward the end of your remarks, you mentioned the issue of guaranteed issue.
Right.
And the problem with free riders who don't buy into the system until they actually get ill. What are your thoughts about alternatives to a mandate? I have a feeling you have some thoughts about that, and I'd be interested in hearing.
Yeah, I've written extensively on that, including here. And by the way, the book's $20. You can get the Kindle version for $10, or if you've got a Amazon Kindle app on your phone, you go into and get the sample, which is the introduction in the first chapter. That's everything you need to know about the book. The rest of it's, if you're a true geek and want to dig into this stuff, it's great. So don't buy the book unless you like physical stuff. What was your question? Oh, yeah. How do you prevent what we actuaries call adverse selection? Here's the problem. You open a supermarket, and all you sell is health insurance to anybody that comes in the door. You want health insurance? Come in and buy it. Walk down the shelves, find the benefits and the price you like, buy it, check out, and you're insured. Here's the problem. Who walks into the store and actually buys this stuff? Sick people. Because if you're healthy, why would you do it? Because every dollar you spend, you want to make sure you're going to get at least $1 back. And the only way you do that with health insurance is if you're sick. Well, the problem is you look at the cost of treating a whole population. 80% of the cost is going to come from 20% of the people who are sick. Now, you never really know from year to year who those 20% are going to be. That's why insurance works. If you get everybody paying into the system, 20% of them are going to get sick. The costs are going to be paid by the 80% who are healthy, and they're willing to do that because they know next year they may be part of the 20%. But if you let the 20% pick themselves once they know they're there, that's all the premium you get. And you die. There's no, a lot of states tried to do guaranteed issue without covering that, what we call adverse selection, and all of them died. All of them went away. A whole bunch of states back in the 90s did that, mostly in the Northeast. So the key is, how do you assure that you get a representative sample of all people in, so that the healthy people are coming into the supermarket as well? There are two ways to do it. One is mandates. You say you don't have a choice. You got to come in the door. If you don't, we're going to penalize you. And but in the case of the Affordable Care Act, the penalty is so small relative to the premium. You say, I don't care. That's what's killing the Massachusetts plan, because they let people come in anytime they want. People come in, they stay in an average of 4 months, they get their hips replaced, their knees replaced, their hearts transplanted or whatever, and then they leave. They don't even pay after that. Gratitude. But so that's one way, mandates. The other way are through controls, a lot of which have been used forever. Medicare, for example. When you turn 65, you're eligible to sign up for Medicare. Part A is covered, government pays for it, doesn't cost you anything. Part B and D, you have to sign up and pay a premium to the government for it. If you don't do it when you're first 65, you say, hey, you know what, I'm going to wait. I'm going to wait till I get sick. Two things happen. First, you can't sign up until the next open enrollment period a year later. So if you get sick in the middle of the year, you're on your own. The government has no mercy, no sympathy. A year from then, if you sign up, you can do it, you can come into the system, you're going to pay higher premiums. I think, if anybody knows for sure, I think it's 10%. Every year you stay out, when you do come in, you pay a 10% per year higher premium. If you wait 3 years, I think it's a 30% higher for the rest of your life. It's a penalty for that. I list, I think, somewhere between a half a dozen and a dozen different techniques for putting that in place up front, where you tell people, you cannot game the system. If you stay out planning to come in when you get sick to beat the system, we have rules in place that can't do it. And the central rule is this. If you come in when you're first eligible and you buy into the system when you should, you're pooled with everybody else who comes in, the big group. If you stay out, really for any reason, as long as somebody's willing to pay for you, if you stay out, we assume you're gaming the system to wait till you get sick. So you know what? During the next open enrollment period, you can come in, but you're going to be pooled with everybody else who's gaming the system, which means your premiums are going to be far higher. That has to be the rule from day one. It has to be made widely, broadly known, publicized like crazy, so people can't come back and say, I didn't know that. And there will be people who do that, will test the system. We'll need to drive them into bankruptcy if that's what it takes to prove the point. And you'll get everybody in. Because it turns out that virtually everybody in this country has somebody else willing to buy their voucher and pay for them. So there's really not a reason not to sign up for insurance. You got Medicare, Medicaid, Children's Health Program, and all these employers. Quick story. I've been conducting an informal poll for about 5 years. By virtue of what I do, I get in front of a lot of CEOs of companies, mom and pop up to Fortune 500, one-on-one or in groups or whatever. And whenever I can, I always ask this question. I said, look, you all provide health benefits to your employees, right? Right. I said, okay, if you had the option to stop doing that, just get out of it altogether and take the money you're spending and give it to your employees, and they could only use it for health care, but every single one of them had an option, at least one option, to buy equal or better benefits at equal or lower premium, would you do that? You just stop doing it, give them the money, knowing every one of them can be as well off or better off under the new program. I've kept rough count, 98% have either said yes or hell yes, and the other 2% think it's a trick question. What we need to do is put together the kind of market where individuals can go into it without being able to game the system, with effective controls to prevent it that you made widely known. And then with people voting with their own dollars, I think you will begin to find that the health plans that are providing crappy providers and crappy care and crappy customer service are going to go away, just like virtually all the old indemnity carriers did when the HMOs came in. And they're going to be replaced by primarily hospital and physician-based health plans that really have their act together. They're only letting in the best providers. They do the best care, lowest total cost. Providers make a ton of money if they do it right. And that they're going to get all the market share. I call them strategic ACOs. Yeah. But accountable care organizations. It's kind of a generic term. I actually have a 4-level hierarchy. You don't want to know. I charge a lot of money for that. And I'm a consultant in real life. So, you know, that to my mind is, and if we do that, if we do it for Medicare, we're not going to be limiting the growth in Medicare spending. You're going to see a doubling of the quality of health care, which is pretty mediocre in average right now in this country. You can see a doubling of quality, cost descending by 5 to 10% for the next 5 to 20 years, until health care is just another affordable necessity of human life. And the potential is there, because 40% of what doctors do is worthless, 75% is preventable, 31% of healthcare dollar, just the cost of billing and collection. I mean, it's like you walk into Walmart and you get your own personal checkout person following you around the store, writing down every time you buy something. You give them your credit card and they won't tell you how much the total is until 60 days later. Most hospitals have more billing clerks than they have beds. It's like having a person with a cash register right outside every door. It's nonsense. It's nuts. Transaction costs should be 2 or 3%, not 31%. I can tell them how to do it. So, is this the last question? Yeah.
Actually, Terry, unless
I'll give shorter answer.
I have
Yeah.
a couple of questions too.
Okay, I'll hang around.
Unless these
Yes, Steve.
Yeah.
You touched on in the beginning, initially, Dems top down in terms of monitoring, Republicans bottom up in terms of monitoring providers. Did I understand you correctly? You were really focusing on providers.
Uh-huh.
And you were talking about the Democrats addressing it top down.
I'm talking about, they want, there's top-down controls over the spending versus the bottom-up.
That's correct. That was a
choice.
large part of the initial part. What are your thoughts on, and you just sort of gleaned there, and it's a turn of phrase that bipartisan is called goring the ox. No Republican, no Democrat wants to hear this.
Right.
In terms of solution, where you are going to address the consumer, forget the providers, let the fee-for-service go on. You address the consumers assuming the responsibility for most everything in their lives from a healthcare standpoint. And that deals with, you talked about the 6 different factors, the 6,
Right.
the obesity, et cetera, preventive.
Yeah, right.
But whether you are Republican or Democrat, you come up with a solution where the consumer is the major factor and the major participant. Forget about what the providers charge. Do you have that in terms of your solution?
I'm not quite sure I understand your question. I'm sorry.
You're putting, if you want to call it this, the cart before the ox, if you want to have it, or the cart before the horse, that the consumer is going to be the driving factor. Their well-being, their responsibility, their choice is going to drive. And you started to go over there, that if you do not take care of your own health, if you're not responsible for yourself, somebody's not going to come in and entitle you. Right. I mean, one example is, you probably know this stat, in an emergency room, do you know the percentage of non-emergent care in the United States that walks into the ER?
Oh, the portion of care that goes into an ER that's non-emergent is huge.
It's huge. It's over 50%.
Yeah, yeah.
And guess what happens to under a new system? Guess what happens to those people?
Well, if they can't find a primary care doctor, they go in the emergency room.
No, they're turned away. It's a new system. No politician wants to proffer that as a solution.
Oh.
They are
I
turned
don't
away.
either.
They're absolutely turned away.
I don't either. There's a federal law called EMTALA that says emergency rooms have to take you and stabilize you, evaluate you and stabilize you. I wouldn't change that.
You do that by triage.
Yeah, no, absolutely.
And triage costs a heck of a lot less than.
It's
I'm just
certainly
saying,
does.
have you, in terms of all your advisory and your solutions, come up with this as an idea? None of your political friends want to hear this, I don't think.
Oh, there's nothing in here my political friends want to hear. It's because there is a downside. I mean, somebody, there are costs, there are trade-offs, which I haven't talked about. I've talked about the upside. But every time you change something, somebody is, I mean, if you cut the cost of healthcare, if you just cut out the waste in the system, cut out the, more billing clerks than beds, you're cutting jobs. Healthcare is supposed to be one of the great job creators, especially now. But it was like Milton Friedman was in China like 30 years ago. And they took him out and proudly showed him these workers with shovels and wheelbarrows constructing a canal. And Friedman said, with bulldozers, you can hire a lot fewer people and do this a lot faster. He said, oh, Mr. Friedman, you don't understand. We have to put all these people to work. And Milton Friedman says, then why don't you give them teaspoons? I mean, that's the pushback you get. You've got an incredible number of non-value-added workers and functions and people in healthcare. If you rationalize the system, the creative destruction is going to require people to leave. But all the issues you deal with, that you bring up, I think I address.
I'm delighted to hear that there is a solution to this in any rational form, and yours sounds extraordinarily so to me. But I'm terrified by the thought that the only ones that can affect this change are politicians. Is there a scenario, a reasonable, rational scenario under which changes of this nature could be made, even if Romney would win and take his Ryan thing into thing? Unless they control both houses, chances are this thing will get torn to pieces. There's no way. They may not even be able to eliminate Obamacare. Is that right or not?
In my view, in terms of fixing this system, the core is creating an individual market where, as I said, people can buy their own insurance as a starting point, control all their own money. That cannot spontaneously arise in the marketplace for reasons I can describe. It's what economists call legitimate market failure. It's like pollution. Pollution doesn't solve itself. You do have to have some level of regulation. Unfortunately, that's true to have an individual insurance market. It turns out, though, you can set up the rules within which, the boundary rules within which an insurance market can function really, really well. And it's just three very simple areas of regulation: eligibility, benefits, and rate setting. And again, it's all covered here. That's all the government has to do, in my view. And then change the tax policy and have a more rational safety net program. Those are the key pieces.
Tax policy and what?
Right now, employer insurance is not taxed. If you get your insurance benefits from your employer, you pay no tax on it. This came out of a World War II thing, which is not, by the way, why we have employer-dominated insurance. That would have happened anyway. It's a natural market for it. So that's why so much of health care is provided through employers, because it's not taxed to the employee. It is tax deductible to the employer. Individuals don't get that benefit. I think at the very least, individuals should get the same benefit. It should be tax neutral. So the individual insurance exchanges, if people could deduct from their taxable income the cost of that, to put it on a level playing field with employer insurance, I think that would be sufficient, as long as you had separate safety net provisions for people who just don't have the money and the capability of doing it. The really scary piece, the really scary piece of the Affordable Care Act is the insurance subsidy for everybody who goes in the individual insurance exchange. who makes less than $88,000 a year for a family of four will now get a government subsidy. As far as I know, it's our first broad-based middle-class welfare program, entitlement program. That's why they've written the rules for the exchanges to dramatically limit the number of people who can get in, to try to keep the employers to keep doing it. The problem is if they fix the exchanges where they really work well by regulating those three things I mentioned, and that's all, those exchanges have the potential to become so efficient and so effective that no employer in his right mind is not going to do what I just said, give the employees the money and said, you go into the exchange and buy it. And by the way, every one of you who's making less than $88,000 a year is going to get a government subsidy on top of it. That is a budget buster. That's the poison pill. That's the toxic noose. So,
The one question I have is, any reference in your book or in the legislation regarding medical malpractice lawsuits and the verdicts that are given?
yeah, I talk a lot about
Because
it.
foreign countries often have a schedule that
Yeah.
sets a maximum for each particular injury.
Med-mal I describe as the world's worst conceivable form of quality assurance.
The doctors I know all complain about the cost of their medical insurance.
Most of the people who are hurt by malpractice never get any awards. Most of the people who get awards were never hurt. I mean, it's just a horrendous system. That said, it's about a 7% problem. If you fixed it, if you just made it totally fair, and you'd get the cost down to probably 2 or 3% of total healthcare costs. That's a one-time hit. It's a lot of money. It's a great thing to do. It does nothing to solve the long-term structural problem of healthcare.
Steve, may I just, not to prolong this for
And it is-
everybody, but
it is in-
I think there are a couple of things that haven't been covered. One is the pre-existing condition question
Right.
and where that would fit under, for example, a Romney-Ryan
Right.
universe. The second is, I think that the insurance exchanges as contemplated in the Affordable Care Act are state-specific still.
Right. Mhm.
And what does it take to make any exchange not state-specific or any insurance provider be able to provide insurance across state lines?
Right.
And is that a good idea? And all of this, I think, ties into the question of, you referred to creating a market. How do we know that if the Romney-Ryan plan, for example, in some universe gets implemented, that a fully functioning market will arise and that it will be successful? And we'll all think that we
Yeah.
have this wonderful system where we can get great care for reduced cost.
One of my big disappointments is Romney-Ryan doesn't address the individual market, like I would say, other than the fact that Obamacare has one in it, they want to get rid of it. It's a bad idea. And in fact, the way the exchanges are constructed, from an actuarial standpoint, I don't see how they can possibly work as legislated. On a state basis,
Under the Affordable
under the
Care.
right now as written, they can be fixed. To me, it's a very straightforward fix, and I just described 3 areas: boundary regulation, you get the state out of it. You don't even have the state run it. You get rid of the subsidy, and they can be incredibly efficient. I like the idea of interstate purchases of insurance, and I'll tell you where every insurance company in the country would end up. It would be in Boise, Idaho, because Idaho has the lowest level of weird mandated benefits that have to be covered by insurance of any state in the union. Maryland is the worst. I mean, anything remotely resembling a health care benefit is covered in Maryland. Massachusetts covered, you have to cover wigs. Wigs for cancer patients. And there are a lot of that's arguably functional, but there are a lot of them that are really weird. Interstate purchases.
Pregnancy benefits for men.
Yeah. Boy, I'd like to underwrite that one. That's an actuary's dream. Anything you charge, right, goes bottom line. So I like the idea of interstate insurance sales because it would put a brake on the practice of, if you got a kid or a relative or a person or your legislator and you have a constituent that has some kind of remotely medical problem that's not covered by insurance, you're going to put a bill through the legislature that says, we're going to cover this. And everybody looks at it and says, oh, it raises healthcare costs by 0.4% a year. Big deal. Insurance companies come in and say, nah, this doesn't make any sense. And they say, go away. There's really no organized opposition against it. And you get all the mothers, you know, and you know what the initials DAM stand for, Mothers Against Dyslexia. They show up. Think about that, Mothers Against DAM. They all show up and the bill passes. And when you end up with a couple of hundred of these, you just double the cost of health insurance. So that's the advantage of interstate insurance. I forgot what your first question was.
Pre-existing conditions.
Pre-existing conditions.
There's a concern that if Obamacare is repealed, the pre-existing conditions all of a sudden will not be covered because...
In individual insurance, that would be true. Because right now you have two markets. You have group insurance that's employer-based, and you have individual insurance where you apply to get insurance from an insurance company. And essentially to get it, you have to prove you're healthy, which makes sense because, again, if you let people get in when they're sick, that's all you're going to get in. But also, with insurance coverage, you're selling coverage against future risks. You don't sell fire insurance on a home for the guy whose house is going up in flames. You know, you don't sell against existing risks. That's a welfare program. That's an entitlement program. We're talking about insurance. So pre-existing conditions, if you set up the program right, pre-existing conditions go away as a problem. Because what we need to have is an individual insurance market where everybody can sign up for care, regardless of pre-existing conditions. Mm-hmm. Because if you get everybody in, or a representative sample of everybody, you don't care. You just start with the 20%, you know we're going to spend the 80%. What you have to prevent is after that, after the start of this thing, that people can't select themselves into the system once they know they have a pre-existing condition and they can game the system. That's the key. But there is no fundamental reason to lock people out for pre-existing conditions. And we got to have a system that allows, everybody needs health insurance. Everybody needs it. Everybody should have access to it. But we should do it in a way that actually works in an economically sustainable fashion and drives higher quality and lower cost.
There's one more question, and then we'll quit.
Okay, thank you. And I'll make it really quick. Do you like the exchange bill that passed in the Colorado legislature this year?
It's all right. I mean, as exchanges go, it's okay. They're so constrained by the federal law in terms of what they can do. I don't think any of them are going to work very well. You know, it's Colorado's arguably more proactive. Not arguably, is more proactive than most other states in moving toward the exchange. My hope, there's a provision in the Affordable Care Act that says in 2017 states can apply for a waiver on almost everything that the feds are requiring them to do. And Obama at one point last year actually said, I would consider accelerating the waiver. And the Republicans said, no, 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 we want to wipe out the whole bill. It was a dumb response. Because if you accelerate the waivers, suddenly you get what Romney's saying we need, 50 different state experiments, them all trying different things to see what works. You got Vermont going with a single payer system. You got Massachusetts with their quasi-market. You got Utah with a market coming up. Colorado, I know some of the people on the exchange, very bright people, can start trying things and you find out what works and then you quickly adapt. Utah's changed their law every single year since they set up their exchange about 4 years ago. And that's what it takes. Yeah, federal level can't work. It's just too rigid, too controlled. So if they could accelerate those state waivers, then we could really do some interesting stuff.
Steve, this is an awful lot of information that you've given us.
Sorry.
Really, it's a fascinating discussion, and of course, this is pretty critical to our lives and our politics, I guess, at this point in time. So thank you so much for being here.
Thank you, Frida. It's my pleasure. Thank you for having me. It's very nice of you. Thank you. Okay. Stay in touch.
Thank you all for
Hey,
being
very nice to
here.
meet you. Thank you.